Robinette, Center Coordinator, Executive Director of Neuroscience Centers of Florida Foundation. Thank you so much. We are really, really excited today because we have the opportunity to participate in a program that is a series, as you well know. It's called A Night with the Experts series, even though today is daytime, since we had to reschedule. This is a very important part of the series because our program today deals with symptom management, and we know that you all are very interested in learning more about symptom management. But this presentation is a little bit different. It's coming with a combination. Obviously, you all know we have Dr. Jack Burks, who is an MS expert, and Jennifer Falk, who is our MS social worker, dedicated to creating programs for you all and helping you through your life's journey with MS. So today's program, Symptom Management, What Can I Do? It's more than just a drug. And the reason for this is because we are melding both the clinical side of symptom management and the psychosocial side, where you get the benefit of hearing a different perspective on symptom management. So, presented by Jennifer Falk, our MS Social Work Programs Coordinator, and and as you know, Dr. Jack Burks, he is, yes, we love him because he is a wonderful MS expert. He is the project director for NSCFF. He is the chief medical officer for the MSAA. He also is a clinical professor of neurology at the FIU School of Medicine. And he's an internationally known lecturer. He's been a researcher. He has founded several MS centers throughout the country, the largest of which is the Rocky Mountain MS Center. So we have the benefit of having someone who has been through the A to Z of MS and knows a lot about research, new developments, and of course is a medical doctor. So without further ado, I am going to give the stage now to Jennifer Falk. And one last thing though, as you all know, here at St. Matthew the Apostle Church is where we have the yoga and dance therapy programs which are funded by the MS Foundation, Multiple Sclerosis Foundation. As you all know, they fund a lot of wonderful programs, and we were privileged to get a grant from the MS Foundation to have the yoga therapy and the adaptive music dance therapy, and it's here at St. Matthew's. So now everybody knows where it is, and we hope that you enjoy those two programs funded by the MS Foundation. And this particular program, the series, we got a grant from Genzyme. So just want you all to know that these things are made possible by these two groups that are very, very focused on helping our MS community, just like us, NSCFF. So thank you very much, Jennifer Falk.
Okay. Hi everyone, welcome. Thank you, Tamara. That was great. So we're here to talk about symptom management, and I feel that it's very important for all of you to know as much as possible, and you being here today is a great thing. It shows that you're empowering yourself. You are trying to get as much information about the things that you need to know about to proceed and live healthy lives. So, you know, you've heard of the fear of the unknown, right? So the more things that you don't know about, what happens? You start to get worried, and you start to get anxious, and you start to think about things over and over again. So by being here and educating yourself and relearning things and learning up-to-date information, you're doing a great service for yourselves, but also for your families, for the people who love you and who care about you. And what's great about today is it's all going to be on video. So if we hit on some really great points that you're like, man, I wish my brother could hear this, you can play this back on video and you'll be able to share it with your family. So that's a really good thing. So let's look at symptom management. Everyone here experiences different symptoms, right? And we experience them in different ways. So no two people experience MS in the same way, but there are some common symptoms that we can talk about. So symptoms that are common include depression, fatigue, dizziness and vertigo, heat intolerance, and spasticity. Okay? Does that sound familiar to anyone? Yeah? Okay. All right. Okay. So we're gonna hit on depression first. And I want to talk about different types of depression, okay? I want you really to understand this. There's two types of depression that we're looking at here. There's clinical depression, and I'm going to read the definition, okay? It's marked by a depressed mood for most of the day, particularly in the morning. That can be very strong, okay? There may be sleep disturbances where you can't sleep or all you want to do is sleep, and a loss of interest in your normal activities, the things that you love, okay? So you're just not into really anything. You don't want to watch TV, you don't want to really do anything, okay? You may feel very bad, excessive feelings of guilt, and you don't understand why. These feelings of sadness need to be present every day for 2 weeks in order to have a diagnosis of clinical depression, okay? So I'm going to talk about situational depression, which is also very common in MS, okay? And that's a short-term form of depression that can occur after a trauma occurs or something very bad happens. And that's appropriate, right? So when my grandmother died and passed away, for the next couple of days, I was very sad, and then, the next week I was sad still. But little by little, I kind of got back to my normal self, right? I'm still sad, but you know what I'm saying. So situational depression is a response to an event that occurs, right? And that can be very common in MS, especially in regards to your symptoms, because last week you didn't have something, and then this week you have a numb foot, or your leg isn't working the way it did. So you're going to have the depression in response to that new symptom, okay? So that's a situational depression that you're going to experience. So you could have that every time you get a new symptom, and that's appropriate. But it's different than clinical depression. So I want you guys to understand the difference, okay? So family members, you need to recognize in your family or your partner or your loved one the difference between clinical depression or having a bad day, a bad week, a bad time, but then they bounce back out of it, okay? And everyone, if you have questions, please write them down, okay? Because we want to hear your questions, but we're going to wait till the end to take questions, okay? So possible causes, and I thought this was interesting because I want you to understand why this happens. Are we? Perfect, okay. So it's common in people with MS. People who are diagnosed with MS have common depression. It's common with them, okay. Researchers believe that the effect of MS on the central nervous system and demyelination of certain areas in your brain can contribute to depression. Okay, so there's things going on in the areas of your brain that affect mood, that affect hormones, that release hormones that affect mood, so that can cause depression, okay?
So sometimes you'll feel depressed, but you really don't have anything to be depressed about, but it's because of that?
It could be, yeah. So how long do you wait before speaking to your doctor about clinical depression? I wouldn't wait at all. Clinical depression is a very legitimate and treatable symptom that you need to communicate with your physician with. And Dr. Burks is going to talk about in detail how to do this and which physician to communicate with, because that's something that comes up often for us. Do I speak to my neurologist about it? Do I find a psychiatrist? Who do I speak to about clinical depression? Okay, so bringing up the subject with your physician, I don't recommend that you wait. And then treatment options include psychotherapy and medication used separately or in combination. So you can go and get drugs or medicine for depression, and you can go and see a licensed mental health professional, a social worker like myself, or a psychiatrist to work out the issues while you're using a medication. Okay, and that would have to be done consistently. Your medication has to be taken consistently, and seeing the professional mental health person has to be done consistently. together they can work very well. Okay? Support groups. Many of you are in our support group, the NSCFF Circle. Yay. Okay, and also support groups for your family members, which we also have. So as you struggle with depression, the people who love you also are affected by depression, okay? And communication, okay? It's very important to talk about how you're feeling and not be alone in that experience. Dr. Burks is going to hit more on different antidepressants. Antidepressants can help tremendously. There are side effects, and every person responds differently to antidepressants. Some people, if you try one and it doesn't work, go back to your doctor and tell them, I'm still not feeling better. But you have to wait 4 to 6 weeks because antidepressants take some time to work. It's not that you take it one day and then the next day you're better. It's not like an antibiotic. It takes some time. So after 4 to 6 weeks, if you are having terrible side effects or you're not feeling better, go back to your doctor and say, hey, this isn't working. I want to try something else, okay? And then Dr. Burks is going to really let you know what types of medications you can talk about with your physician on, okay? So Dr. Burks, I'm going to hand that over to you.
Thank you, Jennifer.
You're welcome.
It's great to be here. It's great to talk with you again. I want to talk about a couple of things, sort of housekeeping. First of all, if you're like me and you forget to turn your cell phone off, please turn your cell phone off so we can do that. And two, since we're recording this for a national audience through the MS Foundation, thanks to Chris from the MS Foundation who's here, it's also going to be on for the radio. I don't know if you're aware of the MS Foundation's radio, but I would suggest you go to their website and learn more about it. Chris just set mine up for me today, and I want to thank him for that. And that I want to let you know what I think my goal is today, and I think what Jennifer's goal is today. It's really to help you become the best consumer for your own health care, so that you know what you need. You know what the landscapes are. This is not a comprehensive course in multiple sclerosis. This is an hour of discussion of what we think is the most important things for you to think about. It's going to generate questions. We want that. And so I would suggest that you all have paper and pencil at the table. Jot down your questions so we can have a lively discussion with the question and answers after our presentations. And so what I'm doing is I'm just going to briefly talk about medications for depression. I'm not going to go into details. This is not a comprehensive list. There are probably 20 or 30 different medications. These are just some examples of the drugs that you may run into. And the group of drugs is called tricyclic antidepressants. And Elavil is one of many. And they can be very helpful. And every drug on here can help certain people. And no drug on here works for everybody. So it's up to you and your doctors to try to figure out what's the best shot you have of being helped. And what do? You measure the potential help and the potential side effects. Like if you're having trouble sleeping, you better not take one that increases your energy because it may keep you from sleeping. And that other drugs actually may help your sleeping. So discuss that. If you're having bladder or bowel problems, there are certain ones that actually may be helpful for that as well, and others that may be irritating that. So the key here is that one size does not fit all. And that's one of the messages to take home from here. You become educated about what the issues are, and you discuss this with your doctors. For depression, some of my patients are treated with their primary care doc, and they're very comfortable with that, and that works well. Some of my patients are treated by me and as a neurologist, and some of my patients are actually treated by psychiatrists. And there is no best. It depends on the situation, the doctor's interest, et cetera. So you need to be able to have this information for all of your doctors when you discuss it. So I hope that, this will stimulate you to look more into some of these medications. Another general category is something called SSRIs. And there's, again, a whole group of these. Prozac is probably the most common one that we talk about most of the time. And it can work very nicely. But some of my patients actually may feel anxious on it. They may have trouble sleeping on it. So it's not good for everybody. But that's why you have to be informed about what are the potential issues here. Discuss it with your doctors. So I can't emphasize that enough. Then there are a number of other medications. Desiril, Sirzone, Wellbutrin, Effexor are some of the ones I've mentioned. I've not mentioned a lot of others that are also very good. But I will leave this slide saying this is the information you know to discuss with your doctors. These are your decisions. If a doctor says to take something and you don't think it's a good idea, you're not going to take it. So why don't you work together, be transparent with what your feelings are, say, I'm nervous about that, doctor. What are my other options? Be your own best consumer. Okay, now I'm going to talk about something that Jennifer didn't touch on, but it's a confusing point when you talk about depression. Because I'll go into a patient, a new patient will come to me, and I'll say, oh, hello, Mr. Smith. It's very nice to meet you. And he'll start crying. He's very pleasant. Really, he doesn't look depressed. He'll just start crying. And he may cry for 30 seconds. He may cry for 10 minutes. And I've had people cry for 30 minutes. And they can't say anything without crying. It's an involuntary crying or sometimes laughing. People will be at a funeral, and they can't stop from laughing. This is inappropriate behavior, often exaggerated to the circumstances. You may go to a movie, and it may have made you feel a little sad before. With multiple sclerosis, sometimes it makes you feel overwhelmingly sad, and you can't stop crying during the whole movie. One of the reasons for bringing this up is it's not depression. That's why you're crying. This is a separate entity called pseudobulbar affect, or PBA, and one of the reasons for bringing it up is that it's potentially treatable. We now have a treatment. It affects up to 10% of MS patients, so it isn't like it's a rare phenomenon. But the condition itself is under-recognized, and obviously then it's under-treated. We also see it in brain injury and stroke patients as well, but it's not well recognized by the medical community. People tend to think people are depressed. So again, something to think about. So the next slide is how do you manage this? And I'm going to just talk about a drug that's FDA approved. It's called Nudexta. And this tells you how to take it. You start taking it a capsule a day, and then you go to a capsule every 12 hours after the first 7 days, after you've gotten used to it. There are reasons for not taking it. If you have heart problems, et cetera, again, talk to your doctors. But it's generally well tolerated. And usually you can see results in a couple of weeks. And it's amazing. Some people see terrific results. It's something for you to be aware of. Most patients aren't aware of it. Frankly, many doctors aren't aware of it. But I wanted to bring it to your attention because it's not depression and it is potentially treatable. So I'm going to turn it over to ask Jennifer if she has any tips that she might have for us as far as depression goes or pseudobulbar affect.
Well, I think that, with pseudobulbar affect, it's a very public symptom. Okay, so it's not one of these invisible symptoms that only you experience. The people around you experience it as well and may not understand it. So by educating them on what it is, it takes away a lot of the confusion and a lot of the wonder of what is happening to you, so they understand your experience. So something that you can let people know that this is what's happening, this is your experience, this is why, and now you know that there is a treatment option for it. So that's a good thing.
Yeah, I usually tell this my MS moment.
Your MS moment, I like that.
If you can't hear that, and maybe at the end we'll start. When you ask us questions at the end or have comments, we'll repeat that because there's an audio audience as well who may not be able to pick this up, and she calls it her MS moments. That's a nice way to think about it.
It is nice. Okay, great. So I'm going to touch on fatigue now. So fatigue is one of the most common and debilitating symptoms of MS. It affects approximately 80% of people living with MS. Fatigue is often one of the most common reasons that people have to stop working because they're just unable to function physically because of the fatigue. From a show of hands, how many people knew that there are different types of fatigue? Okay, good. So I wanted to just go over that, right? So a normal fatigue is the kind of fatigue when you go out really late and you're at a party and you don't get home till 2 in the morning and then you have to go to work the next day and you're exhausted, right? That's normal fatigue. And you have a cup of coffee and you push through and you get through the day and you go to bed early. Next day you're okay. Okay. So that's normal fatigue. And then there's something called short circuit fatigue. And this happens in MS, and it's caused by overworking physically. So you want to go to the gym, and you feel good that day, and you're going to lift weights. And then you're like, I still feel good, and then I'm going to go on the treadmill. And then you're going to go for a walk outside and walk the dog. And that could really knock someone out, right? So you might have overdone it. But that can resolve in a few days with rest and recuperation also, right? So that's short circuit fatigue. And then there's something called lassitude. Okay, so this is called MS fatigue. This is that fatigue that I was talking about, the 80% of the people who have this. It's different than a regular person that just gets tired. I have a lot of patients that tell me, you know, they're suffering from fatigue, and then their wife comes home and says, yeah, I'm tired too, I worked all day. But it's different. It's not the same thing as being tired from work. So symptoms of that type of fatigue include experiencing it on a daily basis. So every day you feel this way. You may have this feeling after sleeping a good 8 hours. You wake up and you're still exhausted. You feel tired, you take a shower, you got to lay back down and rest again because you're still tired. Does that sound familiar to anyone? Okay. Okay, so it tends to be accumulative. So the more you do throughout the day, it adds up. So your cup just gets full and full and full. And then by the end of the week, it can be accumulative that way as well. Okay? It can be aggravated by heat and humidity, and it can come on all of a sudden. So you could be having a great day, and I've heard people say it's like someone put a spell on me, and I just couldn't function anymore. So you just get hit all of a sudden, like hit by a wall, right? I see a lot of people nodding, yes. So you know it's happening because it interferes with your daily activities and your responsibilities. So you know, you may have vacuuming to do and a sink full of dishes, but you just can't do it because you are just that tired. And as quickly as it can appear, it can be gone the next day, and you'll have a great day. So there's an unpredictability factor, and that's hard to manage because you never really know what's going to happen. And that's why I brought family into this, because the fatigue, of course, is impacting you, but it also impacts the people who love you and the family that you live with and everyone around you. So the person who experiences fatigue may be struggling with grief, frustration, guilt, and anger. Grief. What is grief? So grief is feeling sad over the loss of something. So you have grief because you're so fatigued. You've lost the ability to do the things that you might have been able to do a week ago. So that is a true and valid experience, the grief. But not only you experience it, the person who loves you experiences it as well, because they also grieve the loss of the things that you were able to do a month ago, okay? To jump in the car and go to Disney or whatever it was. So this is a valid experience not only for you, but for your family members. Frustration, guilt, and anger, these are very common feelings that come with fatigue. You're frustrated. You can't do the things that you want to do. You feel bad. You always feel bad, very apologetic. And then your family feels bad also because they also have the guilty feeling that they still want to go to Disney, right? But we can't. So there may be an adaptation period, and you guys learn how to adapt and have a plan B, okay? So this unpredictable factor, always the family will learn to have a plan B. So maybe we can't go to the movies tonight, but we're going to rent a movie and stay home. And friends have to understand that sometimes you guys can't make it, you know. Learning to be flexible with your plans and develop coping mechanisms as an individual and as a family. And if you have trouble with this, it's very good to seek professional help because they can teach you and as a family how to develop coping mechanisms to deal with this. And communication about your experience. When people don't understand what fatigue is and they say, yeah, well, I work too, I'm tired. I read somewhere, and I thought this was a great analogy. Pretend you're putting on a full bodysuit, right? And in the bodysuit is weights everywhere, in your hands, in your arms, in your legs and torso, and then start out on your day with all of these weights, right? So this is a good way to explain to your family. After a while in this weighted bodysuit, you're going to be exhausted. You're going to run out of steam. So that's a good way to try to communicate exactly how it feels to be that fatigued. Or if you ever were really sick and had the flu, you just can't even lift your head up off the pillow. That's the kind of fatigue that you could try to explain to your family members how it feels. So we could go to the next slide. So some solutions for fatigue. And I know that Dr. Burks is going to speak to you a little bit about it, but there is pharmacological help. There are medications that you can take. As Dr. Burks talked about before, there are certain antidepressants that have a stimulant effect. So they give you energy. So that's an option. So even if you're not suffering from depression, there are medications that are antidepressants that can give you some energy. These drugs do have side effects, so this is always something to talk about with your physician. Some people feel that keeping a healthy diet, keeping a well-balanced diet and vitamins are a good benefit and can help with some fatigue. And then to manage your activities. If you know that in the morning you have more energy, plan and prioritize the things that you need to do in the morning. And then the next day you may have to do the rest and rest in the afternoon. So being organized and conserving energy. So to have an organized home and an organized area so you don't have to waste your energy looking for your papers, looking for your whatever it is, helps to conserve energy. So little tricks that will help you not waste energy during the day. And plan ahead. If you are cooking and you like to cook and you're having a great day, you can cook on Sunday and double batch it and freeze it. So if you're having a day that you're fatigued, you open that freezer and you have a meal ready. So little things like that, planning ahead, knowing that fatigue could hit you, and being prepared can help you have an easier day when the fatigue does hit. And I know that Dr. Burks wanted to talk to you more from a medical perspective on fatigue, and he has some tips here in terms of the type and the recommendations. So, Dr. Burks?
I can't overemphasize enough the issues with fatigue. It's a problem that almost every MS patient has to deal with. And the point I'll make, in spite of what your children say, or your husband or wife might say, this is not normal fatigue. Everybody gets fatigued. They say, oh yeah, fine, yeah, I get fatigued, I understand. They don't understand until you've had MS fatigue. It's a much more debilitating thing. And so part of this is educating people about the MS fatigue is very different. And this talks about, from the neurologist's perspective, that you have the normal fatigue, and Jennifer talked about that very nicely, and you can, if you're up late at night, you can rest and catch up. But I really want to talk about the myelin damage fatigue. What's happening with the myelin damage, or the MS fatigue? And remember that myelin is an insulating material. That's one way to look at it. And the brain is an electrical system where you get the idea in your brain, but you want to move your left hand. That is generating electrical energy that goes down, an electrical message, goes down to the spinal cord, out to the nerve, to the muscle, and I move. Well, if you don't have insulation, if the myelin is damaged, it takes a lot more energy to get that message through. And that energy depletes the brain of the energy, and you feel tired, and you feel very tired. And that it can really interfere with so many activities. And so what Jennifer's talking to you about is ways to compensate, ways to save up your energy. If you have to go shopping, do them in the morning, because by the afternoon, the brain is fatigued, and you're fatigued for that. There is also something called deconditioning, and again, people who have MS say, I can't exercise, so they gain weight, they don't exercise, just like anybody else. The key is exercise is important. And you're going to hear a lot more about exercise as a way to help build your stamina, help your cognition, help your mood. Exercise is a way to combat fatigue. People say, I'm too fatigued to exercise. That's when you need to talk to your doctor, talk to your physical therapist about what you can do to incorporate an exercise program, because you may find that if you're in better condition, you'll have less fatigue. Depression. People sometimes don't realize that people who are depressed feel fatigued. People who are depressed that don't have MS know it's part of fatigue, but when people have fatigue and depression and MS, they say, well, they're not related. Well, they are related. Depression can increase your fatigue dramatically. So therefore, it's important to get counseling and medications for your depression, as we talked about before. The other thing people don't talk about or think about is their medications. There are a lot of medications that can cause fatigue. So you need to make a list of your medications. Ask your doctor, which of these may be contributing to my fatigue? And you may find that if you switch medications, your fatigue will get dramatically better. And the other thing, as one of my colleagues once told me, if you have multiple sclerosis, you may have other things. And her analogy was, you can have fleas and ticks at the same time. So remember, I always remember that analogy. So just because you have MS doesn't mean you may not have thyroid problems. It doesn't mean you may not have anemia. It doesn't mean you may not have an infection someplace. So don't just say, everything is my MS, I can't do anything about it. You can do things about it. And the key is to be knowledgeable about what are the other issues and think about those so you can help your doctors manage your condition better. Now the next slide is how I look at management as a neurologist. And it's really great to have Jennifer here because she really takes it from the patient's perspective, and I tend to take it from the medical perspective. So it's a nice balance. But I think it's important. Cooling is important. Maximizing your energy. So if you got to do something, if you got to take your kids to school, you know, maybe you shouldn't plan 3 other activities that morning. So use common sense for that. Stress is an enormous drain of energy. So think about that. Weight control. If you can reduce your weight by 10%, you'd be surprised how much more energy you might have. Another incentive to lose weight if you are overweight. Then there are a number of medications on this slide. Simitrel, Provigil, Nuvigil, Cylert, Prozac, and also CNS stimulants. I'm not going to spend today giving you a lecture on medications and the side effects and all that, but keep these in mind. And ask your doctor about these. Because some of the doctors will say, I don't feel comfortable with this, but I feel very comfortable with this. And considering your situation, this seems like a really good idea. Many of these drugs are not FDA approved, but we found they can be helpful to certain people, but not to everybody. But if you know about them and understand about them, and again, what I'd suggest you do, if you're having something like really bad fatigue, write these down. Make a list. Ask the doctors about, these are the concerns. I've read about this, this, and this, and this. You can say, I heard it from Dr. Burks. Blame it on me. It's okay. And say, what do you think about this? And get their opinion. Because all of a sudden, you'll be a good consumer of your own health care. Jennifer, do you have any other extra tips for fatigue management?
I think that you got it. I like that we talked about exercise. And I really want to emphasize, guys, that we have adapted exercise. So even though if you do feel tired or fatigued, here in this room every week we have 2 classes being given that are adapted specifically for MS, and they still are exercise. I've tried it. It still works my muscles, and it's hard, but the yoga is sitting in a chair. The dance music therapy is also sitting in a chair but getting up as well. But they're good exercises to try to work with that fatigue and get your energy back. So I did want to add that and try to encourage you to get involved in things like that. Okay.
I think you bring up another point is in this room. This is an example of how MS organizations, patient organizations work together. This is a program that Jennifer may organize, but it's actually a program that's funded and supported by the MS Foundation. So we have 2 different organizations. And some of our programs are actually involving 3 or 4 different organizations. We're all working together to help people with multiple sclerosis. And this is a good example of that.
That's great. Okay, so we're going to touch on dizziness and vertigo. Getting dizzy, sitting back up, standing up, and sitting down, right? So the causes in MS. Vertigo, first I want to talk about what the experience is. Vertigo is the sensation that your surroundings are spinning or that you are spinning in your surroundings. So it seems like everything is moving around you. It's common in MS. It could feel like you might have drank a lot. It's almost like walking around like you're intoxicated or you're off balance. You keep losing your balance. Moving your head up and down or side to side makes it worse. The experience is increased. And it's a result of damage to the pons region of the brainstem, which this is the region that controls balance and motion. So that's why this happens. It can come on in an intense way for people who have MS, and it usually improves. But there may be some leftover things that occur. You still might be a little bit dizzy afterwards, even though you kind of have evened off after the experience. So what can you do? This is something, again, to communicate with your physician this experience and what's going on. To try to get, if that happens to you, try to get in to see your physician while it's happening. There are medications such as Antivert, Valium, motion sickness medications that can help. They do make you very tired, some of them. They can make you tired, so something to keep in mind. But at that point, if it's so bad, that's something that can help. Dramamine can also help. And I thought this was interesting, vestibular rehabilitation therapy. Has anyone heard of that specific type of therapy? I thought that was very interesting. In this picture, it's not very big, but you can see it's a specific type of physical therapy that treats vertigo.
Well, heat intolerance is a neurologic phenomena, and that the electrical system in the brain, the myelin, if it's damaged a bit, it doesn't work quite as well. When the body heats up, the system doesn't work as well. So the impulses don't get through. So it may be that a patient of mine can play one set of tennis in 90-degree weather, and they're fine, but the nervous system wears out. The impulses wear out. And it doesn't mean they're having an attack of MS, but they may have old symptoms come back. They may have something new that they're feeling funny about. They may have decreased vision in one eye, for example. And if they rest for 20 minutes in a cool place, it comes back. So it isn't like your brain's being destroyed. The damage is already there. It's just not very efficient. So it does it okay for a while, but then it sort of wears out, and it gets fatigued, and you feel new symptoms or recurrence of old symptoms usually.
Thank you. So I always like to understand why this is happening, not just know, okay, I know this happens, but why? So, I mean, the good news, as Dr. Burks mentioned, once the body temperature is cooled down again, usually the symptoms will go away, right? So like, remember when we were children and we had fever and your mom would put like wet washcloths on you to try to bring down your body temperature? Those are things that we need to do if you get overheated. So you can see here, we talk about wearing light clothing if you have to go outside, loose-fitting clothing, which absorbs less, light colors absorb less heat. Cotton always breathes well versus synthetic fabrics, right? Fill a spray bottle with water and keep it in the refrigerator in your house. So if you're working and doing housework or doing yard work and you get hot, just keep that cold water available to you and cool yourself off. I know another person that always freezes bottled water and takes it with them when they leave. So they've got frozen bottles of water in the car, and you know, eventually it melts, but you've always got it there cold. You could put it on your pulse points, on your wrists, behind your knees, on your ankles to try to cool off your neck. Taking a cool shower will lower your body temperature, like when you were little and had that fever. Exactly. That's true. Yes.
I've been doing it for a long time.
The ice bucket challenge, yes. And that also could help cool you down. Okay, staying in the shade. Don't go out in the direct sun at noon unless you really have to. It's really hot out there now in the summer in South Florida. There are hats now that have these cooling inserts that you can keep in the hat. So it's a wide-brimmed hat, but you could insert like ice inside the hat. And also cooling garments. I don't know if you've all seen these, but the vests, the cooling vests, you can wear under your clothes. You can wear wristbands that are cold, ankle bands that are cold. And I have that information if anybody needs that type of equipment, okay? And I'm going to hand it over to Dr. Burks, who's going to talk about spasticity a little bit.
Thank you. Many of the things that Jennifer is talking about, especially as she was talking about vertigo and dizziness, it came to mind, and that it was often people will have maybe a severe episode of vertigo or spinning, and then they'll get better, but they're not totally better. And she mentioned this, and I think it's important for me to emphasize it, and because falling is a real issue. And if you're turned quickly and you're not balanced properly, even though you may not be having an acute vertigo, it makes you unbalanced. So you must think about safety. Monitor your movements. Some people will use a cane just to be able to get that balance. It's important. The other problem with it is it's neglected. Well, you're sort of over your dizziness. Well, you don't have to worry about that anymore. You never have to stop worrying about it. If you're still feeling a little queasy or uneasy when you're walking, you need to get something done about it. And a lot of people say, well, it's not bad enough to bother my doctor. Well, you need to rethink that. Because if it's creating an issue for you, ask your doctor. He may well be able to help you in many ways for that. So now I want to talk about spasticity. What is spasticity? You hear that word a lot, and it means different things to different people. There are actually many forms. We tend to think of it in general as a muscle stiffness or rigidity in the muscle. They just don't move quite as fluidly as they used to. But can also mean involuntary contractions. People can have spasms, and many people have nighttime spasms. The muscles get really spastic at night. It may come in episodes. And mention that to your doctor, because there may be ways to help you for that. There's something even called spinal cord seizures. Now, these are not epileptic seizures, just so you know, but we call them that in MS patients, where a patient may all of a sudden have an arm that goes up like this for 30 seconds. And they can't control it. They don't know what's going on. Or maybe a leg. And we call them seizures because it's sort of like it's stiff and it may shake a little bit. This is not an epileptic seizure. But it is treatable, potentially. So if you don't mention it to the doctor, you're not going to have access to that treatment. So spasticity occurs in many different forms. And so the next slide is what to do about it. I think the first thing to do about it is exercise and stretching. And stretching, you know, you get up in the morning and you do some stretching exercise. It's amazing how much less your spasticity may get over the day. Aquatherapy in the water. People are cooler. Jennifer, you're doing some aquatherapy things. Do you want to talk about that?
Yeah, we do have aquatic therapy available off of Bird Road. I know some of you already go, and it's a great exercise. There's stretching and there's resistance with the water. Even just walking in the water and stretching out your legs, there's wonderful benefits to that, and that can help the spasticity. So if you need information about the pool, where that class is being given, I have that for you.
Other things, physical therapist. It's really something that physical therapists are very good at addressing. Also, occupational therapists can be very helpful with this. So you have these resources. And also, it may be that if you're having spasms and causing safety issues or you need adaptive equipment, you may be able to use this. For example, if the foot goes down and starts shaking too much, you know, you're going to catch your toe. But if you get something to lift it, it may be helpful. There are a variety of ways that your rehabilitation therapists can be helpful in reducing and managing your spasticity. Now I'm going to give you a whole bunch of medications, because I'm a doctor. I'm supposed to do that. And we have a variety of medications for spasticity. And again, I'm not going to tell you you should all be on this drug or this drug or this drug, but these are the type of drugs that we use for one reason or another. And they include oral baclofen, which is a very common drug that we give for spasticity, probably the most common. But in people who have severe spasticity, we actually can put tiny doses of baclofen in the back next to the spinal cord. And that can be very helpful for people. It's a major help for people who have terrible spasms, especially in their lower extremities. Zanaflex, Klonopin, Neurontin, Diantrium, Valium, and Botox. Botox is now approved for spasticity. Did you know that? For upper extremity spasticity. May be helpful in other things as well, including bladder spasticity. Talk to your doctor about where might Botox fit into your armamentarium for things to do. The last thing I'm going to talk about is cannabis. And cannabis keeps coming up. Marijuana keeps coming up. It's not legal in Florida, is it?
I don't think so.
I don't think it's legal in Florida. But it's legal in New Jersey, and it's legal in Colorado, other places where I practice. And there are farms in California for this. And that, I'm just going to I'm going to stand on my soapbox for just a minute, please. I ran the Rocky Mountain Multiple Sclerosis Center in Denver, Colorado. I founded it and ran it for the first 20 years. And it was very close to a place called Boulder, Colorado. And Boulder, Colorado has a very high incidence of people who smoke pot. So a lot of my young patients were pot smokers. And I was very concerned. It can help pain, it can help spasticity, it helps a lot of different things. But what I've been concerned about in my soapboxes is we don't know what its effect is on cognition. We know that MS can affect cognition significantly in some people and moderately in other people. And anybody who's ever smoked a joint knows how it can affect your cognition acutely. I mean, it's not easy. There was a very famous physician and philosopher. He was also a musician. Jerry Garcia, a deadhead. One of his famous quotes is, "Pot makes you stupid." And I think he was right, even though he was a rock musician. And that I'm very concerned, not just it makes you stupid when you smoke it, but it may have some long-term effects. If you have a toxic condition of the brain called multiple sclerosis, and you add another toxin to that, is it going to be temporary or can it be permanent? And I don't think we know the answer to that yet. There is some data that would suggest we should be concerned about that. So I'm saying if I have other options for people, and I've got all these options for people, why don't I do that first? Marijuana is so easy, just smoke it makes you feel good, everybody feels great, but what's it doing to your brain long term? So I don't know the answer to that, and the data is mixed, but I wouldn't take a chance. If there's any other way to deal with your spasticity, I would go there first. But it's being legalized in a lot of areas, especially for medical marijuana. If you have cancer, I'll be the first to write you the prescription. You know, if you have terminal pain, you need marijuana. If that helps you, but your MS is going to last the rest of your life. It's not going to go away, and we know that the brain can be affected, not only the insulation but also the gray matter of the brain. And I really don't want anything that might interfere with that. So I just think you should have some degree of caution before you start smoking pot for multiple sclerosis. Jennifer, you may have an opposite opinion about marijuana. I don't know.
I have no opinion
I'll
on
tell you, my
marijuana.
friends disagree with me dramatically, my non-physician friends. But my MS expert friends tend to say, yeah, we're concerned too.
It sounds pretty right on what you're saying.
And we'll have a discussion at the end. You know, ask your questions, and we can talk to you about some of the more specifics. But I want to get to some other topics. And the next topic is stress. And I really want Jennifer's comments about this as well. Just think about getting a diagnosis of MS. Think about the word stress. They come hand in hand. The lifestyle changes. The marital status sometimes that is affected. The employment that's affected. The financial issues that are associated with having MS. It's a very stressful condition. And so having the disease can cause stress. And likewise, when you're under a lot of stress, do you notice? We're all under stress. Your MS symptoms are often worse. So therefore, managing stress is critically important. So I believe that everybody, whether they have MS or not, should understand stress management techniques. They should learn progressive relaxation, guided imagery, whatever your thing is, manage your stress. I think stress kills people, not just with MS. I think stress is a major issue in our lifetime. And I think we all need to learn how to manage our stress better. Counseling can be very important to help put the stress into perspective. Medication for stress. Yeah, there's some medications that work pretty well. And I don't like to use them for MS patients. I mean, maybe if their grandmother dies, yeah, for a week or two to get through it, but not long term. You need more and more and more. It's hard to get off of them. I found that they have considerable problems. So I use them very sparingly, and I use them for very short periods of time. Xanax must be one of the most common prescriptions written in the United States today. And it's like the marijuana. Be careful what it's doing to your body otherwise. Jennifer, what do you think?
Well, I think that sounds great. I just want to emphasize stress management for people who are living with MS. I mean, the initial diagnosis, but beyond the initial diagnosis, the constant challenges that you're put up against makes you constantly have to reassess how you are managing your stress. And it's not easy. Not everybody has to do what you all have to do. So seeking support, again, I can't emphasize enough, through exactly what you all are doing here today. You're here with people just like you, you're supporting each other, and then also to get professional help if you need it. A licensed mental health professional, a psychologist, a psychiatrist, someone that you can see counseling for every week can really help. But also in terms of stress reduction, I'm going to plug away at our things that we're offering you guys too. The adaptive yoga, it's very relaxing. You really don't have an option once you get into her class. You're going to leave relaxed. Breathing techniques. We are also fighting for a mindfulness grant that I think we're very close to getting. So that's also teaching imagery and ways to actually physically relax yourself and be able to do that on your own at home when you're lying down in bed at night. So these are all things that you all need to focus on, especially because of what goes on in your life every day. So we are always looking to give you more tools to help you with that.
If I had to name the top few things that I think you really should focus on in living a higher quality of life, stress has got to be very close to the top of that list. So take it seriously, because I think you can feel better. You can have a higher quality of life if you learn how to deal with stress. You can't get rid of it, whether you have MS or not. So learn how to deal with it. Okay, now I'm going to talk about thinking problems, cognition, memory problems. I'm old, but when I started in MS, I was told dogmatically MS can never affect cognition. It hasn't been that many years ago. We were absolutely told never. It's a white matter disease. It's a myelin disease. It's only a problem with insulation. It doesn't affect your thinking, so don't you worry about that. It's the one thing you don't have to worry about. And as I noticed more and more of my patients having that issue, not often they didn't talk about it, their family members talked about it. We now know that over 50% of MS patients have some memory loss. And then I was told, okay, fine, they have it, but don't tell them. Don't tell them, because we don't have anything to do about it. We can't help them, so pretend like it doesn't happen. Well, don't you pretend like it doesn't happen, because there are things to do about it. Only 10 to 15% of memory issues are actually recognized by the patients. Higher, recognized by the family members, but not by the patients. And the key is that if you know what you're dealing with, there are lots of ways to compensate for that and to learn. I mean, we're learning that the brain has plasticity now. The brain can actually learn different things, different ways of doing things. And so take advantage of that, those new discoveries on how the brain works. Short-term memory is obviously an issue. Now, everybody has short-term memory problems. We don't remember everything. We go to the grocery store, we don't take a list, we forget 2 things. This is really different for MS patients. Recall, trying to remember something that you're trying to recall. Learning new information can be difficult. One of the things that I find most difficult with my patients that is actually fairly easy to manage is multitasking. My MS patients are not good at multitasking. They can't do 4 tasks at once. And so I have a patient who's a quote, middle-level executive. What that means in a big city is they're in a room with a cubicle with 100 other people with cubicles in the room. And they're constantly being asked this, that, and the other thing. And they have trouble getting through their workday because they're being interrupted. And when they get interrupted, they have trouble getting back to the original task. So what do you do about it? Say, well, they just can't work anymore. Not true. You work with the employer, give them a corner room with a door and blinds. And when they're working on a project, they are focused on that project. Their work performance goes up dramatically. and their quality of life goes up dramatically because they're not having to deal with all of the multitasking that's required. So there are ways to deal with this, and there are ways to get you help. So I'm not just saying this so, oh, I'm scaring you. I'm not trying to scare you. I'm trying to say if you recognize the issues and you work with people, you can actually overcome. You can adapt to the memory problems. And that, so anyway, I'm not going to talk about the rest of those. It's called executive functions, trying to integrate all of the various things in your life to say, what does that really mean? Sometimes that can be an issue. Some people have no problems with that at all. And also problem solving, especially if you're trying to solve really complex problems. You have to break it down into the individual problems. So the next slide is how do we manage it? Well, the first thing I do when somebody says, I think my memory's not very good, I look at their medications. We give MS patients a lot of medications, and guess what? Some of them can cause memory issues. So the first thing I look at is saying, what medications are you on? Is it associated with a memory issue? Because if you have 10% memory issue, and you take a medication that can cause memory, it may be 30%. All of a sudden, it's noticeable. So look at your medications. Look at your anxiety and depression. People who have severe anxiety, people who have severe depression, or even moderate anxiety or depression, don't think as clearly. And it's not just MS patients, it's everybody. You know, when you're under stress, sometimes you lose track of things. And there are now cognitive retraining programs. There are experts who say, we'll teach you how to organize your life better so that your cognitive issues are much more manageable. And they're compensatory. Simplest thing, write down things. Take notes, make a list. I mean, everybody can make a list. Anybody who has memory issues, not making a list, I can change your life by just making a list. So when you get back to the grocery store, you only forget 2 things as opposed to 10 things. Anyway, and do one task at a time. Really finish a task before you start another task. Are there drugs for cognitive issues? Yeah, we use some drugs. I don't particularly. The Alzheimer's drugs, I don't think are very helpful. So I'm not encouraging people to take those, the Alzheimer's drugs. Sometimes I use them, and some people feel a little bit better, but overall, after several years of trying it, I don't think they add much to the treatment of MS. But what may be helpful is Jennifer's tips. So Jennifer, tell us, how do you deal with cognition problems?
It's a tough topic, and many people who are experiencing it do know. Some don't, and some do, and it's very frustrating. I think you definitely hit on staying organized. I know many people rely on their phones and reminders and calendars a lot. There's even apps for reminding you to do things, Post-it notes. I'm interested if you could possibly explain where a neuropsychiatrist comes in terms of diagnosing cognitive issues, because that's a question that comes up a lot.
That's a great question, because I think it's important to document the level and the type of cognitive issues or neuropsychological that you're facing, because some people have very different issues than other people, and you treat them differently.
Right.
So if you don't know what the problem is, guess what? You're probably not going to get a very good treatment for it.
Right.
So I believe that neuropsychological testing is important, along with counseling. If you just get the neuropsych testing and they give you all this stuff, scares you to death, and you don't know what to do about it, that's bad. And as a matter of fact, when we did this, we always had a licensed psychologist give the test, not just a technician. Because what people found when they took the test, they had more problems than they thought they had. And they go through a mental breakdown right there. I mean, it really is very distressful. So it's important to learn the right ways to deal with their cognition, and also to deal with them on an emotional basis as well, and which turns something into a disaster into something that can be productive. And I want to go on to another topic that has been neglected, I think, for many years in multiple sclerosis. That's pain. At the same time we were telling people that they didn't have cognitive problems, we were also telling them they didn't have pain. That pain was not part of MS. And that was true. Only 75 or 80% of people have pain. Not everybody has pain, but it's a very common symptom, and it can be very much related to multiple sclerosis. There are 2 types of pain I want to talk about. One is what we call the central nervous system pain that's caused from a myelin damage within the brain itself. This pain can be burning, searing, stabbing. It can be acute or chronic. It could be this terrible pins and needles feelings that people get in their hands and feet. It can be lightning sensations. It can be all sorts of things, burning. This is part of the MS disease itself. And we treat it differently, and we look at it differently. The other part of pain is musculoskeletal pain. It's achy joints, achy muscles, back pain. If you have weakness in your back, or if you don't do exercises and you're doing, and you're not properly lifting things, or you have a bad mattress, or you have posture problems, that can be much worse in MS patients because they have a weaker system sometimes. Their muscles are weaker, so they don't compensate as well. And I call those musculoskeletal pains. And I treat those like I treat other musculoskeletal pains. But the MS pain, the central pain, is what I want to talk about next. So let's look at the next slide. Talks about a variety of treatments that we use for central nervous system pain. And usually when there's a variety of treatments, that means there's no one treatment that's going to be great for everybody. But some of those include the drug called Neurontin, Cymbalta, Tegretol, Elavil, Dilantin. So those are all drugs that we use for other purposes. It can also be helpful with pain. We also use biofeedback and relaxation to help pain. It can be very helpful for patients. Acupuncture can sometimes help my patients very much. So I think we need to consider the complementary alternative ways of looking at pain as well. And cannabis, marijuana. I do believe that people taking marijuana feel better. They feel great. I feel wonderful, doctor. Okay? And again, I'll take the same precaution as before. I would try other things first. As far as the musculoskeletal part, rehabilitation can be very helpful. Strengthening those muscles that are weak can be very helpful. Strengthening muscles that may not be affected with MS so they can overcome the problems with muscles that are affected with MS, may be able to compensate. And also I think that minor analgesics can be helpful. Motrin, aspirin, things like that can be helpful. I do not recommend narcotics, except in the extreme, extreme, extreme situation. First of all, they don't work very well with central pain, the MS kind of pain. They're not very good. And second of all, they cause addiction. So you're given a drug that's not going to be very helpful. It's going to make people addicted. So I'm very reluctant to give narcotics for people with MS pain. But I'd be interested in Jennifer's thoughts. Jennifer, what do you think about pain?
Well, I think it's something challenging. I think it's an invisible symptom. So it's not anything that your family members can see, your loved ones can see, your physician can see. So, you know, it's hard to get the often validation or recognition of what's going on, your experience. So to communicate really exactly what's happening with your pain to your family members, to your physician, and not let this take over your life. Don't wait and wait and wait. Really address it. If there's someone that doesn't help, there's a physician that's saying, no, you know, there's nothing you can do, keep searching for someone else that can help you because there are things out there. I also wanted to add massage therapy. I've spoken to people that has also helped them very much. I don't know if that's something that you recommend, Dr. Burks?
I recommend any sort of relaxation, stress management, massage therapy is part of that whole garbage. But biofeedback can be very helpful as well. Acupressure, acupuncture.
Yes.
Lots of complementary alternative medicines can be helpful getting people through the pain cycle. So that's a really good point. Thank you for bringing it up.
Great. Thank you.
All right, I'm going to switch gears and talk about tremors. I'm going to go from the invisible symptom called pain to the very visible symptom called tremors. Fortunately, it doesn't happen to that many patients with multiple sclerosis, but a lot of people with MS do have tremors. And it's important to recognize that. And that there's a list on one side that talks about the medications we use. And there's a lot of medications on that side because none of them work very well, in my opinion. That doesn't mean we don't try them. And some people actually get very good results, but it's not very common. Medications are usually not very good for people with tremors. The best medication is to put people asleep. If you're asleep, you don't have tremors. And I'm not sure if I had tremors, I'd want to be asleep all the time. So you have to weigh the risk and the benefits of these potential therapies and try to find a happy medium. There are other ways, what I call non-pharmacological treatments. Bracing can be helpful to reduce the tremor. Weighting, like if I have a person who can't eat because they have very severe tremors, if we put a weight on their arm, sometimes it calms down the tremors so they can eat better. That's what we talk about weighting. And also there is a surgery for Parkinson's disease. And Parkinson's disease, as you know, is tremor. That's one of the manifestations of Parkinson's disease. And it may be helpful in certain patients with multiple sclerosis, but not everybody, and you need to talk to your doctor about that. So if you have a severe tremor, especially if it's on one side, it'd be worthwhile to talk about your doctor about the possibility of a deep brain stimulation. Comments? Jennifer? Tremor?
Well, I think it's good to know if there is a tremor involved so much that it affects your ability, say, to hold a spoon or to brush your teeth or to shave. Gentlemen, there are actually adaptive devices that you can attach to your spoon, to your razor, to your whatever tool you're using to help with the tremor. You know, and also I want to talk that this is a visible symptom. So if you're at work and you have a tremor, now people can see it. So that really brings up the question: do I tell people about my diagnosis? Do I want to make this a public announcement that I have MS? People can see the tremor. So it kind of brings up different feelings in terms of telling about your diagnosis or not telling. So that brings up thoughts on that as well. So that's something to think about.
Thank you.
Yeah.
I'm going to finish with just a few other symptoms that I think are important, at least for you to be aware of, that there are treatments for them, and that one of the things that confuses a lot of people is bladder problems. Well, I have bladder problems. Well, it turns out bladder problems are not bladder problems, are not bladder problems. There are three different types. One is a small spastic bladder that it fills up just a little bit, and you have to go right away. You're running to the bathroom constantly. You just can hardly hold it. Well, the treatment for that is a drug that actually relaxes the bladder, decreases the spasms in the bladder. And then there is this large bladder where it has very little muscle tone whatsoever. It's like a big balloon. It doesn't contract at all. Well, obviously, you don't want to give those patients the drug for the small bladder, so you have to find out what kind of bladder problem you have. And that, in fact, I don't think any of the drugs work very well for the large bladder. That's where we really need to talk about something called intermittent catheterization, putting a catheter in and draining. It sounds terrible. It's actually not that terrible. And if it allows you to have an evening out without having to worry about things, about leaking, stuff like that, it can be very helpful. One of the problems with a big bladder is that if you don't empty it very well, the urine goes back to the kidneys. So when you get a urinary tract infection, you get a kidney infection. So it's a very important, it's a very serious healthcare problem. The last part I'll talk about is when we urinate, the bladder is like this. The bladder wall contracts, and the sphincter at the bottom, the funnel, relaxes, and the urine flows. Well, what if the balloon contracts, but the funnel closes? That's what happens in sometimes. We call it dyssynergia. It has a name for it, and again, it can be helped sometimes with medication and with self-catheterization. So there are things to do about this, and there are more extreme conditions, but I'm not going to talk about those today. Jennifer, do you have any comments about bladder issues?
Yeah, well, I just think that it's important to address. Obviously, it affects your social life. It affects your ability to leave the house for long periods of time. And since there are solutions, it's something to talk about. It's nothing to be embarrassed about, to talk about with your physician and address.
And that's really a good point. Yeah. I mean, it ruins people's social life. It ruins their relationship life. They won't do anything because they're afraid you're going to have an accident. And if you have activities where you have trouble getting to the bathroom, you learn that very quickly, whether you have MS or not. But the bowel can be trained. There's something called the gastrocolic reflex. The gastric, stomach, colon, bowels, there's a reflex. When you feel the stomach, that reflex is activated. MS, sometimes that doesn't work very well, but it still can work and can help you. So if you actually develop a bowel program, and you combine that with exercise and certain fibers and things like that, can be very helpful. I'm not going to go into the details of that today, but I'm just telling you, there's help available for you. And the last thing about a bowel problem is people don't know that depression can cause bowel problems. It can cause constipation. People who are depressed have constipation. So therefore, it may be another reason for getting your depression treated. It may help your bowels. Then the next area is sexual problems. Here, Chris is always ahead of me. Thank you, Chris. The sexual world, and at least American society, is very interesting. It's like the military. If you don't ask, if I don't ask, you won't tell. People don't like to talk about their sexual problems. And these are manageable problems that affect most people with MS. And so this don't ask me and I won't tell you is not very productive. And so when you look at the sexual dysfunction issues, one of the things I like to start with is the psychological issues related to sexual dysfunction. About I feel my self-esteem is bad. I feel just badly about myself. I'm depressed. I'm anxious, and my libido is sort of low. And I'll ask Jennifer to comment on that in a minute. But the other is medication effect. It's amazing the number of medications that we give people that can affect their sexual problems. Not just the blood pressure medicines, but other things as well. And that this is just a reminder that, that sexual problems are part of most people with MS lives, and they can be dealt with. You want to talk about psychological factors, Jennifer?
A little bit. I mean, you know, it's a topic that doesn't come up a lot because people don't like to talk about it. But, you know, with MS, it can affect your whole image of yourself, how you view yourself as a person, how you view your sexuality. Your body image can change because you may have lost weight, gained weight, look a little different than what you used to look like. And your self-esteem can be affected, and that can also affect your sexuality. And depression as well can have lead to a low libido. So, you know, I think it's important for people who are in relationships to talk about these things. And if you really have trouble with it, again, I can't emphasize enough to speak to a social worker, speak to a therapist that can open a couple up to talking about sex. And remember that intimacy is not just intercourse, you know, touching, holding hands, laying in bed talking. Things around intimacy also bring people close together. So that's something to just keep in mind. But it's definitely something that can also be discussed with your physician. So don't let that fly by because it's a great part of life that you can continue to enjoy.
Thank you. The next slide, we talk about the treatments. And Jennifer touched on some of these. The first thing is education. Understanding sexual dysfunction and how it might affect you. Get emotional support to this. Redefine sexuality. You know, in the Playboy era, it was like, you know, sex was having sexual intercourse. Now we're much more enlightened to that. Sexual intimacy is much more than having sexual intercourse. There's so many other ways to express your intimacy issues with your partner. And if we talk about females, I think probably the best thing I recommend for females with sexual dysfunction is the saying that there is no such thing as too much lubrication. Lubrication can be very helpful. People who have painful intercourse, it's one of the best things that you can just use lots of lubrication. It reduces the pain, it reduces the irritation sometimes. And so, and remember, water soluble. Don't use Vaseline. Vaseline sticks, it doesn't evaporate, and you get infections. Vaseline is a harbor of infections, and you get bladder infections with Vaseline. So use the water-soluble lubricants. Another thing is sometimes the stimulation is just not enough with manual manipulation or sexual intercourse. Vibrators have been very helpful for people with multiple sclerosis. And so I highly recommend, if you want to have more stimulation, use vibrators. I think it's important. One of my colleagues, a lot of people have pain. A lot of women have pain. They get spasms in their adductor muscles and their thighs, and they can't do it. So one of my colleagues, Dr. Randall Shapiro, who's a famous MS expert who wrote the book on symptom management in MS, recommended frozen peas. Now, people don't really understand about frozen peas, but he's made a national issue of this, is that, but if you cool the external genitalia area, you can reduce some of that irritation, some of that pins and needles, some of that spasms that are going on there, to reduce the spasms so you can have more successful sexual intercourse. For males, there are vacuum pumps, and you've all heard of Viagra, Cialis, and Levitra. Those can be very helpful. And there's even, you can even do a penile injection to stimulate an erection. So if it's that important, and that's what you want, there are ways to accomplish this. What do you think, Jennifer?
I think that sounds good.
Okay. Enough said, huh? Okay. All right, I'm going to finish with trouble speaking and trouble swallowing, something we never talk about hardly. But 25% of people have speech problems. And this can be from weakness, poor coordination, can be spasticity, and it can be just fatigue itself. And the key is, don't suffer from it. Seek help. There's a specialist, a rehabilitation therapist called a speech pathologist, a speech and language pathologist, who can be very helpful in getting you to speak more slowly, more clearly, more understandably, and it'll brighten your life considerably. And because it's people don't speak, but if they have trouble speaking, they just don't talk. And that's a very bad thing to do. The last symptom is swallowing. It's amazing. People don't talk to me about their swallowing problems. 20% of MS patients have swallowing problems. The patients overlook it. Well, and if you ask them, they'll say, oh, well, I do choke on certain foods, or fluids do come up through my nose, but I just hadn't thought about mentioning it to you, doctor. Well, when that happens, if fluid's going up through your nose, maybe it's also going into your lungs and could cause pneumonia. You know, if you're having trouble swallowing, please see your physician. And again, the speech and language pathologist is an expert at that. They can actually do the testing to see how the swallowing works. Are you swallowing into your lungs? Are you swallowing into your stomach, for example? If you can change the consistency of the food, will that help? People eat too fast in this country. And people who eat too fast in this country get fatigued. And so they do fine at the beginning of the meal, but by the end of the meal, they're choking. They're not eating properly. And so pneumonia is a serious issue. And the problems with swallowing can be related to pneumonia. Please seek help. Jennifer, comments?
You have just to remember to find out through the speech pathologist in terms of how you can manage your food and the texture of your food if that's an issue. There's ways to thicken liquids and there's ways to soften foods if that is an issue for you. So that's the only thing I can really recommend there. Yeah.
Thank you. Well, I'm going to end my part of this before Jennifer takes over again for the question and answers is a summary. What have we talked about today? Do you realize how many things we've talked about today? We've covered a lot of multiple sclerosis today, and I would bet that some of you have never heard half of the stuff that you're hearing today. And hopefully you'll become better educated and better consumers for your own health care. And that realize the ways that you can be helped are rehabilitation, lifestyle changes, counseling, obviously things like this, like education. Medications can help many areas. Surgery can be an option for some of these conditions. And probably the best thing I can teach you is common sense and sharing your issues with your healthcare professional. And so with that, I'll turn it over to Jennifer. Thank you very much.
Thank you, Dr. Burks. That was great.